It's fine right there, right? Okay, so I am going to do the best I can under these circumstances. So welcome to Nursing 3, and we are going to get started with GI. The first thing we want to talk about is GI anatomy and physiology. So you need to understand how things work when they're working properly in order to understand what happens when they don't work well anymore. If you take a look at that reference sheet that I did put up on Teams, you'll see the anatomy of the digestive system. So you've got your mouth, and in your mouth you have salivary glands. That is the first step in the digestive process. Your mouth and your teeth have the ability to chew the food, to break it up into smaller particles. And then the salivary glands put out saliva that has enzymes in it that actually break down the food even further. It goes past your pharynx when you swallow it, down your esophagus, through the lower esophageal sphincter, which is kind of like a one-way valve between the esophagus and the entrance to the stomach. And it's only supposed to go one way. It opens to let the food move down through the esophagus and into the stomach, and then it's supposed to swing shut. For some people with GERD, which we will talk about in a little while, that doesn't work properly for many reasons. And if that valve actually gets stuck in the wrong position, the hydrochloric acid that's in your stomach can kind of ease back up the esophagus and cause that feeling that we are familiar with, known as heartburn. So your heart is really not burning, but your esophagus, which is made of a soft endothelial cell lining, very smooth mucosal lining, hypersensitive to that strong acid that's in your stomach, and it burns. You can feel the burning kind of climbing up the chest, hence the name heartburn. So while in the stomach has folds inside of it that enable it to kind of stretch open a little bit to allow for the entry of that food. And then the hydrochloric acid gets made and released, breaks down the food into a pureed substance that we call chyme, C-H-Y-M-E. Kind of looks like pureed baby food. Once the food is broken down, it exits the stomach through the pyloric sphincter and enters into the small intestine. Small intestine, about 20 feet, give or take, of small intestine you have in your stomach, in your abdomen. And you can remember it by remembering DJ ileum, the duodenum, the jejunum, and the ileum. So the ileum is the distal portion of the small intestine that then connects to the large intestine, also known as the colon. All absorption takes place in the small intestine. So as that chyme is moving through the small intestine, your body is pulling through the small intestine into your blood carbohydrates, which are basically sugars, proteins, heme and non-heme, which we'll talk about even more, lipids, which are fats, and then there are different enzymes that are available to help break down those substances. You have accessory organs also that aid with that. The gallbladder, for example, which is in the right quadrant of the abdomen, is a storage facility for bile. And bile is necessary for a couple of reasons. Bile actually helps to metabolize lipids, fats. And also, bile is the thing that adds color to your poop, to your feces. So people that do not have a gallbladder, initially, because there's such a profound lack of bile available, they cannot eat fatty foods. If they do, they have to eat them in very tiny increments. And they're going to have bowel movements that are gray in color. They almost look like chalky in appearance because of that lack of bile. The liver, which we're going to talk about in depth, performs many, many functions. When I ask people, what does the liver do? They say it filters. It does, but so much more than that. And we'll get to that. Anyway, so from the small intestine, we go to the large intestine, or the colon, and you've got the ascending colon, the transverse colon, the descending colon, ends in the rectum, and then Uranus, which is always funny to me. And that's where in the large intestine, basically feces is formed, right? As that, whatever's left over after the absorption's taken place in the small intestine, the waste is basically what's left. And as it travels through the large intestine, it gets some water mixed in with it, et cetera, and forms the stool, which then is excreted when you go poopy, okay? When we talk about the diagnostic tests that you definitely need to know and need to understand the nursing implications for, first one we'll talk about is something called guaiac your stool, or also known as a stool for occult blood. The word occult, OCCULT, actually means hidden. And so what we're looking for is blood that's not actual frank red blood that you can see, but blood that is hidden in the stool. It's usually secondary to a slow GI bleed. For example, a patient that's been on NSAIDs like celecoxib or meloxicam for a very long period of time, or aspirin for a long period of time. Those medications can actually cause a very slow GI bleed. And so you may not see the blood in the stool, but it presents itself with something called melena. In other words, the stool actually looks kind of black and tarry looking. And when we do this guaiacing of the stool, or stool for occult blood test, we can then in the lab find that hidden blood that's in the stool. Guaiac is Guiac, and that means the same thing as stool for occult blood. The procedure for that is the patient is given something called a hat, not the kind you wear on your head. It's the kind that fits over the toilet. And when they have a bowel movement, they actually have their bowel movement in the hat. And they have a little kit that's got a card. The card opens up and it's got 2 windows. And it also comes with 2 small wooden spatulas. The patient is instructed, or you as the nurse would do this. You take the first wooden spatula, you go to the front end of that bowel movement, take some feces, smear it onto the first window, close the card, dispose of that first spatula. You take the second spatula, go to a different location in that bowel movement, preferably towards the end, take a smearing of that feces, smear that onto the second window, close the card, and then those 2 cards get sent to the lab, and the lab is then able to test to see if there is in fact blood in the stool. So that one you need to know. The others you need to know: endoscopy and colonoscopy. Whenever you hear oscopy, it's OSCOPY at the end of a word, it's talking about a scope, which is a catheter with a camera that is inserted somewhere looking for something. Example, colonoscopy. Colonoscopy is a scope that is inserted into the colon. And when we do that, we are looking for, in that large intestine or colon, cancer, or possibly precancer, or possibly polyps. Polyps are small. They're little growths that can occur in the colon. They're typically benign, which means they're harmless. Sometimes they can be precancerous, and typically if a patient's having a colonoscopy and we find polyps, we'll go ahead and remove them while we're in there and send them to the pathology lab just to make sure that they're not cancerous or precancerous. The other thing that we could find are diverticula. Okay? A diverticulum is a pouching that is in the lining of the large intestine. And that diverticula can actually get filled with bits of food particles that pass through. Example, people with diverticulosis. In other words, they have diverticula present in their colon, those little pouchings. If they eat seeds or nuts, they're little tiny particles, because they come out the same way they went in, they look the same. They can get stuck in those little pouches. And if they do, the diverticula can then become inflamed and even infected. And now, instead of diverticulosis, you have diverticulitis. So colonoscopy can find all of those things. You need to make sure that you know the procedure and the nursing care that goes along with, and the nursing instruction that goes along with colonoscopy. Make sure you read the care plan that's in your textbook. The patient will have a bowel prep prior to the colonoscopy. And what that means is we want to make sure that they're cleaned out so that there's no feces present in the bowel so that when we go in with the scope, we can see everything that it is we're looking for, okay? Usually that's something called, get this, go lightly. Go lightly makes you go heavily. And what it is, it's basically a laxative, but it's kind of super duper laxative. So combination of laxative and sometimes even enemas that are given prior to the colonoscopy to make sure that the bowel has been evacuated, in other words, completely cleaned of all feces, so that when we go in with that scope, we do have a clear view. So read the care plan for colonoscopy. Then we have endoscopy. Endo, meaning within, and endoscopy, we're usually referring to scope that goes down the throat and is looking now into the esophagus. Again, what are we looking for? Possibly cancerous lesions. The other thing we could be looking for are something called esophageal varices, which kind of are dilations of blood vessels that usually are associated with chronic alcoholism. They can become enlarged and they can even rupture. And the patient can wind up with a very severe esophageal bleed. In other words, they're bleeding from inside their esophagus. It's a very scary thing the first time that you see it because the patient's just pouring frank red blood out of his or her mouth. So endoscopy would be looking for varices, looking for cancer, looking for ulcers. The word ulcer itself, it's a very vague word. Ulcer or ulceration means erosion of. So we can be talking about an ulcer that is in the esophagus or in the stomach or in the small intestine. So gastric ulcers, peptic ulcers, duodenal ulcers. We can also refer to skin lesions like decubitus ulcers or pressure sores. They're ulcers too, but of a different nature. Okay, so endoscopy is looking for ulcerations also in the esophagus. The blood work that you're going to need to know that's associated with GI in general. First is liver enzymes. So liver enzymes are AST and ALT. Those are liver enzymes. So if the doctor says, I'm concerned about liver function, I want LFTs done, liver function tests, that's going to include an AST and an ALT. The other lab test that we are concerned with is something called albumin. Albumin is a plasma protein, also related to liver function because of the liver's role in the metabolism of certain proteins and amino acids. So if somebody's got liver disease or liver damage, you would expect to find the AST and the ALT elevated because the liver's not functioning properly and cannot excrete those things, so they're spilling back into the patient's blood. When you looked at albumin, you would expect albumin to be low. Why? Albumin is a plasma protein. If the liver's not working right, liver can't metabolize those amino acids, those proteins, and patient's going to have issues with protein absorption. And then the last thing you're going to be looking at is total bilirubin. Bilirubin is actually the waste product of dead red blood cells. So one of the functions of the liver is that red blood cells, when they have outlived their usefulness, about 120 days, go to the liver basically to die. The liver's kind of like the funeral parlor or the crematorium for the red blood cells. And so the liver will take those red blood cells, the hemoglobin, take the heme out, which is the iron, and then break down what's left of the red blood cell. And the poop, excrement, waste product of that is bilirubin. If the liver's not functioning right, then the bilirubin, instead of getting excreted, it does not. It spills back into the bloodstream. And guess what bilirubin does? It causes a patient to look jaundiced. Jaundice, everybody should kind of know what that word means. It is a yellow tinge to a patient's sclera. Sclera are the whites of your eyes. Also, the soft palate inside the mouth can become yellowed, and the skin, in severe cases, can become yellowed, all due to liver disease. So, again, with liver disease, you would expect AST and ALT to be elevated. Total bilirubin would be elevated, but albumin would be low. And those are all signs that say something's wrong with the liver. Hey! So you need to know those labs. And then another accessory organ, pancreas. Now the pancreas is an endocrine and exocrine gland, so it serves a lot of functions. As an endocrine gland, part of the endocrine system, you all know, because you remember from term 3, that it makes insulin, right? And it also makes glucagon. So that's its role when it comes to the endocrine part. But when it comes to the exocrine function, it makes amylase and lipase. And those are two substances that actually assist with the metabolism, your body's ability to take starches, different starches from foods, and utilize them in a way that the body can use. So those are two labs that you would need to know, amylase and lipase. And we'll go into more detail when we get to the accessory organ part of it, okay? And that's going to be another lecture. So those are the labs and the diagnostic tests that you need to know. When we talk about assessment, remember, when you're assessing, you always want to ask the patient about their own history, any medications, over-the-counters, or supplements that they're taking. You want to ask them about family history, because specifically cancers and all different types of gastrointestinal cancers do tend to run in families. So there are family propensities towards those kinds of cancers. You want to ask them about their eating habits. Remember, the answer, small, frequent meals, is the right answer to every disease. It's the right answer to diabetes. It's the right answer to GI problems. It's the right answer to keep it a nice, good figure and keeping your metabolic rate up high, because your body does not want 3 big meals that are spread 4 to 6 hours apart. What your body wants is little bits of food over the course of the day that it can utilize for the energy that it needs, okay? So we are going to talk in more detail about each of the disease processes, and that's going to be the next video that I'm going to make. For right now, go through the chapter. Just make sure you understand the anatomy that I already talked about, from the mouth, through the pharynx, the esophagus, lower esophageal sphincter, stomach, pyloric sphincter, small intestine, DJ, ileum, the large intestine, aka the colon, ascending, transverse, descending, rectum, and Uranus. All right, that's it for this video. Another one will follow shortly. Peace.